this slide presentation, we're going to be talking about the maternal assessment and fetal heart rate. During labor and birth, various techniques are used to assess maternal status. These techniques provide an ongoing source of data to determine the woman's response and her progress in labor. Because labor is a period of physiological stress for the fetus too, frequent monitoring of fetal status is part of the nursing care during labor. The fetal oxygen supply must be maintained during labor to prevent fetal compromise and to promote newborn health after birth. Baseline fetal heart refers to the average fetal heart rate that occurs during a 10-minute segment that excludes periodic or episodic rate changes such as tachycardia or bradycardia. The normal baseline fetal heart rate is between 110 to 160 beats per minute. Fetal bradycardia can occur when the fetal heart rate is below 110 beats per minute and lasts 10 minutes or longer. It can be the initial response of a healthy fetus to asphyxiation. Causes of the fetal bradycardia might include fetal hypoxia, prolonged maternal hypoglycemia, anesthetic agents, and prolonged umbilical cord compression. Bradycardia can be benign if it's isolated, but is also considered an ominous sign when accompanied by a decrease in baseline variability and late deceleration. Fetal tachycardia is a fetal heart rate greater than 160 beats per minute that lasts 10 minutes or longer. It can represent an early compensatory response to asphyxia, maternal fever, or maternal dehydration. Fetal tachycardia is also considered an ominous sign if it is accompanied by a decrease in variability and late deceleration. Baseline variability is defined as irregular fluctuations in the baseline fetal heart rate, which is measured as the amplitude of the peak to trough in beats per minute. The constant interplay, the push and pull on the fetal heart rate from the parasympathetic and sympathetic systems produces a moment-to-moment change in the fetal heart rate. Variability is described in 4 categories: absent, minimal, moderate, and marked. Absent or minimal variability typically is caused by fetal acidemia secondary to uteroplacental insufficiency. Interventions to improve uteroplacental blood flow include changing the mother's position to lateral, increasing the IV fluid rate to improve maternal circulation, administering of oxygen, documenting findings, and reporting to the healthcare provider. Moderate variability indicates that the autonomic and central nervous system of the fetus are well developed and well oxygenated. It is considered a good sign of fetal well-being and correlates with the absence of significant metabolic acidosis. Marked variability occurs when there are more than 25 beats of fluctuation in the fetal heart rate. Causes of this include cord prolapse or compression, maternal hypotension, and abruptio of placenta. Interventions include determining the cause, changing the mother to a lateral position, increasing IV fluid rate, administering oxygen, discontinuing oxytocin infusion, and notifying the healthcare provider. Periodic baseline changes occur with acceleration and deceleration, which you would notice on the fetal heart rate graph. The fetal heart rate can demonstrate patterns in response to most stimuli. Fetal accelerations are transitory, abrupt increases in the fetal heart rate above the baseline that last less than 30 seconds from onset to peak. They are visually apparent with elevations of fetal heart rate of more than 15 beats per minute above the baseline. They are generally reassuring and require no interventions, and I'm speaking about fetal accelerations. Decelerations, on the other hand, is a transient fall in fetal heart rate caused by stimulation of the parasympathetic nervous system. Decelerations are described by their shape. Early decelerations are visually apparent, usually symmetrical, and characterized by a gradual decrease in the fetal heart rate. They are thought to be a result of fetal head compression that results in a reflex vagal response with a resultant slowing of the fetal heart rate during uterine contractions. Early decelerations are not indicative of fetal distress and do not require intervention. Late decelerations are visually apparent, usually symmetrical, that occur after the peak of the contraction. The fetal heart rate does not return to baseline levels until well after the contraction has ended. Delayed timing of the deceleration occurs and are associated with uteroplacental insufficiency. They imply some degree of fetal hypoxia. Acute episodes with moderate variability are more likely to be correctable, whereas chronic episodes with loss of variability are less to be correctable. Variable decelerations present as visually apparent abrupt decrease in fetal heart rate. The shape of the variable decelerations may be an upside down U, V, or W on the graph. Variable decelerations usually occur abruptly with quick decelerations. Variable decelerations are associated with cord compression. Prolonged decelerations are abrupt fetal heart rate decline of at least 15 beats per minute that last 2 minutes. Many factors, such as prolonged cord compression and abruptio placenta, can be the cause. Fetal heart rate acceleration is a normal response to fetal and maternal pushing. There is no nursing intervention at the time. I do want to point out that in your book, 18-5 in the box, is the cause, clinical significance, and nursing interventions related to late deceleration. Late deceleration is abnormal pattern associated with fetal hypoxemia. The usual priority is you change the mother's position first. So please review that table in the chart. Nursing management of the laboring woman presents a complex physiological process. Nurses must be able to have immediate assessment, identify comfort measures, provide emotional support, information and instruction, advocacy, as well as support for the partner. For most women, labor begins with regular uterine contractions after hours of hard work during cervical dilation and birth, and ends as the woman begins to recover physically from birth. Nursing care management focuses on these assessments with the goal of ensuring the best possible outcome for all involved. We're going to begin by talking with the maternal status during labor. Although not all nurses perform vaginal examinations, most nurses working in community hospitals do so because physicians are not routinely present in labor and birth suites. Vaginal exams are also performed by midwives and physicians. However, you as students will not be doing this. Only by doing it frequently in clinical practice can the practitioner's skill level improve. Looking at the maternal status, we assess the vital signs, pain, prenatal record for review. Vaginal exams, as I discussed, a cervical dilation, effacement, whether the membranes are intact, the fetal descent, and the presentation, as we discussed in the previous slides. Typically, the mom is on her back during the vaginal examination. It's performed gently with a concern for the woman's comfort. The amount of cervical dilation, or opening, and the degree of cervical effacement, or thinning, are key areas assessed during the vaginal examination. Although this finding is somewhat subjective, experienced examiners typically come up with similar findings. The width of the cervical opening determines dilation, and the length of the cervix assessment. Fetal descent and cervical dilation can also determine fetal station and presenting part. During the vaginal examination, the gloved index finger is used to palpate the fetal skull. Station is assessed in relation to the maternal ischial spines and the presenting fetal part. If you recall that on part 1 and 2 on the previous slides, you can refer back to that. Progressive fetal descent is the expected norm during labor, moving downward from the negative station to zero station to the positive station in a timely manner. The integrity of the membranes can be determined during vaginal examination. Typically, if intact, the membranes will be felt as a soft ball that is more prominent during contractions. If the membranes are ruptured, the woman may have reported a sudden gush of fluid. When membranes rupture, the priority focus should be assessing fetal heart rate first to identify deceleration, which might indicate cord compression secondary to cord prolapse. Prolonged rupture in membranes increases the risk of infection as a result of ascending vaginal organisms for both mother and fetus. The primary power of labor is uterine contractions, which are involuntary. Uterine contractions increase intrauterine pressure, causing tension on the cervix. This tension leads to cervical dilation and thinning, which in turn eventually forces the fetus through the birth canal. Uterine contractions during labor are monitored by palpation and by electronic monitoring. Assessment of the contraction includes frequency, duration, intensity, and uterine resting tone. Uterine contractions with an intensity of 30 millimeters of mercury or greater initiate cervical dilation. Leopold's maneuver are a method for determining the presentation, position, and lie of the fetus through the use of 4 steps. This method involves inspection and palpation of the maternal abdomen as a screening assessment for malpresentation. Each maneuver answers the following questions. Which fetal head or part is located in the fundus? On which maternal side is the fetal back located? What is the presenting part, and is the fetal head flexed and engaged in the pelvis? Students will not be conducting or practicing Leopold's maneuver on a woman in labor. This skill is only performed by experienced clinicians. In this slide, it shows you how a vaginal examination is performed. Fetal assessment during labor and birth requires the nurse to identify the following 4 concerns: amniotic fluid analysis, fetal heart rate monitoring, fetal heart rate patterns, other assessment methods. Before we talk about the fetal heart rate, I want to mention the analysis of amniotic fluid. Amniotic fluid should be clear when the membrane is ruptured. If the amniotic fluid is not clear, or is cloudy or foul-smelling or green, this will indicate that the fetus either has an infection or has passed meconium secondary to transient hypoxia. If it is determined that meconium-stained amniotic fluid is due to fetal hypoxia, the maternity and pediatric teams work together to prevent meconium aspiration syndrome, which would necessitate sectioning after the head is born and before the infant takes their first breath. Fetal heart rate requires initial 20-minute continuous fetal heart rate assessment on entry into the labor room, completion of a prenatal labor risk assessment on all clients, intermittent auscultation every 30 minutes, and during second stage of labor, intermittent auscultation every 50 minutes for low-risk moms. Analysis of the fetal heart rate is the primary evaluation tool used to determine fetal oxygen status indirectly. Fetal heart rate assessment can be done intermittently using a fetoscope or a Doppler, or continuously using electronic fetal monitoring, which can be applied externally or internally. Intermittent fetal monitoring involves auscultation using a fetoscope with a handheld Doppler. This device allows the mom to ambulate in the hallway during the first stage of labor. The concern with this method is that the intermittent monitoring does not provide a continuous fetal heart rate record and does not document how the fetus responds to the stress of labor unless listening is done by the provider. Continuous electronic fetal monitoring uses a machine to produce a continuing tracing of the fetal heart rate, and when the monitoring device is in place, a sound is produced with each fetal heart rate. In addition, it provides a graphic record of the fetal heart rate. Remember, normal fetal pattern and heart rate is 110 to 160 beats per minute. The primary objective of electronic fetal monitoring is to provide information about fetal oxygenation and to prevent fetal injury that could result from impaired fetal oxygenation during labor. Continuous external monitoring uses two ultrasound transducers, each of which is attached to a belt and applied around the woman's abdomen. They are similar to the handheld Doppler device. The Toco transducer is applied to the uterine fundus and detects changes in the uterine pressure and converts the pressure into an electronic signal that is reported on the graph paper. The second ultrasound transducer records the baseline fetal heart rate, long-term variability, accelerations, and deaccelerations. Continuous internal monitoring of the fetal heart rate is indicated for women or fetuses to be at high risk. This includes women with multiple gestation, decreased fetal movement, maternal fever, or preeclampsia. It involves the placement of a spiral electrode into the fetal presenting part, usually the head, to assess fetal heart rate, and a pressure transducer placed internally within the uterus to record uterine contractions. This is the most accurate method of detecting fetal heart characteristics and patterns because it involves receiving a signal directly from the fetus. Only trained labor and birth nurses can place the spiral electrode on the fetal head. In this figure, you can see a continuous internal electronic fetal monitoring. You can see the spiral electrode on the scalp, as well as the second electrode in the fluid or in where the fetus is laying.